Good afternoon, and welcome to today's SAMHSA-sponsored webinar titled Family-Led Crisis Planning for Individuals with Serious Mental Illness and Serious Emotional Disturbance, presented on behalf of the National Federation of Families. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC at the bottom of your screen or by clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who should be spotlit on your screen. During the presentation, please add your questions and comments in the chat box, and questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends, please take a few moments to complete a brief survey that will show in your browser as you exit the platform. Thank you again for joining us today, and we will now begin today's presentation.
Thank you so much for being with us here today. We have some really great speakers who will help share their individual knowledge, both professionally and their lived experience and expertise. We hope by the end of today's webinar that you will be able to identify signs and symptoms of serious mental illness and serious emotional disturbance and recognize how those are turning points for families whose loved ones experience those and are at risk for a mental health crisis. We also hope that this webinar will help you understand how to access crisis services through 988 and understand how states and community organizations collaborate to provide those services. Finally, we hope that you learned today how to create a family-led crisis plan for loved ones with SMI SED. And now I'll turn it over to Linda Gargan to introduce our speakers.
Thank you, Dana. Hello, everyone. It's great to have you here with us. I wish we could all be on camera together. You guys know, if you know me, you know I want to see everybody's face. But that is not possible with these very large webinars. So I have the privilege of introducing some amazing people to you today. But before I do that, let me just say to those of you who may not know who I am the Executive Director for the National Federation of Families. And on behalf of myself and our staff, we thank SAMHSA for allowing us to bring this information to you today. And we are so thankful for these three amazing women. I am just going to briefly introduce them because I believe people do a better job introducing themselves. But you will see that we have Susan Terry Ball with us today. Susan's with us from the great state of Oklahoma. She is a certified peer recovery specialist, and she works with Lift Community Action. Sheamekah Williams, also from the great state of Oklahoma, is the president of the Evolution Foundation. And Melinda Brummett is coming to us all the way from Oregon, where she serves with Oregon Family Support Network as a statewide trainer and peer coach. These women are going to share some amazing information with you today. Please sit back and relax and get ready to learn all about family-led crisis planning. Next slide. So before I turn this over to them, because I always like to tell you something, let's look at SAMHSA's definition of a crisis. Now you see that a crisis is any experience of stress, emotional, or behavioral symptoms, difficulty with substance use, a traumatic event that will compromise your ability to be safe or to function. But here's what I want to say to you. This definition is great, but a crisis is what a crisis is at your house and with your family. And you see there are some situations here. If you're looking at this and going, oh, none of these really are the same as what we are dealing with, what you're dealing with is what's important. And please, please, if you are not familiar with 988, please get familiar with 988. It's important that you know that if you call 988, you will get a person who will talk to you, who will work through your situation and will help you find the support you need. And with that, I turn this over to our wonderful presenters. Susan, I believe you're going first, and please introduce yourself.
Good afternoon. Thank you all for joining us today. My name is Susan, and I am from Oklahoma, and I am a certified peer recovery coach here at LIT, and I'm also their case manager. My job duties basically here are when people come into our office, I get their information and I see what is going on with them. And if they are dealing with a crisis, I turn them over to our therapist here. My goal today is to help you understand when you meet someone, whether it's on the street or they come into your office, that you will realize that you can just listen sometimes and be there for them, whether it's your family, a loved one, or anything else. So I'm going to talk to you a little bit about serious mental health illness and serious emotional disturbance and our turning points within our families. So the turning points. As a parent, a family member, or caregiver, sometimes we have to learn the signs and symptoms. And a serious mental illness or serious emotional disturbance in your child is an important first step. So, when you have a child, sometimes you think, I wonder what's going on with my child. I wonder what has happened with a child. Or if you have someone that you're taking care of and you don't even really understand what's going on, you have to recognize some signs and symptoms. So when we begin to recognize and do an exhibit of those signs and symptoms, we can be scared and we get immobilized and it's unsettling. But many parents and caregivers and members are led to turning points in our life when we know that they're headed to a possible crisis where we can stop that and it won't turn into what we call maybe a full-blown outburst or a crisis. So SMI and SED is by SAMHSA defines serious mental illnesses, which is an SMI, as someone over 18 having within the past year a diagnosable mental, behavioral, or emotional disorder that substantially interferes with a person's life and ability to function. It's like having an uninvited guest in your mind, like something you think of or you think something is going on and it might not be. One that a thought might just pop in your head, a quick visit and jump out, or it might just camp out right there for a moment and it starts rearranging the furniture. SAMHSA defines serious emotional disturbances, SED, as someone under the age of 18 having within the past year a diagnosable mental, behavioral, or emotional disorder that resulted in functional impairment that substantially interferes with or limits the child's role or function in family, school, or community activities. So when we talk about serious mental illnesses, I've listed several, just as some examples here, that might impact your family. And conditions that impact a person's thoughts and feelings and actions that frequently interfere with day-to-day functioning, some major depressive disorders with psychotic episodes, or bipolar, anxiety disorder, or maybe schizophrenia. But not every person with the following diagnosis qualifies as someone with an SMI. Those are just examples of maybe some diagnoses. Signs and symptoms could include some behavioral changes, some physical symptoms, or cognitive symptoms. Signs and symptoms, according to SAMHSA's definition, is a mental illness, vary depending on the illness, but they usually affect the feelings, thoughts, body behavior, and connecting with people. Behavioral signs may include avoiding others and social activities and changing sleep or food habits. Physical symptoms may include stomach aches, headaches, or other aches. Common cognitive symptoms include excessive worry, mood swings, and difficulty focusing. Depressive disorder versus major depressive episodes with psychotic episodes. There's many examples here of that. But depressive disorders include mental illnesses with the presence of sad or empty, irritable mood. And when people go through different things in their life, they might think, oh, well, they're depressed or other things are going on, when their thoughts and other things might just be at the moment where they need someone that can say, hey, what's going on in your life? What has happened in your life? Maybe they've been through a situation, different things that they just need someone to sit down and talk to. And that's when you could sit down and talk to them and see if they've depressed most of the day, if they have lost pleasure in doing things that they've done from day to day, if they've had significant weight loss, they're having trouble sleeping, or if they have suicidal ideation. When you talk to them about that, if you're going to harm yourself or harm somebody else, always talk to them about that. Bipolar is like manic depressive. The disorder formally is a mental illness characterized by emotional highs, also known as manic or hypomania episodes, and lows, also known as depressive episodes. Hypomania is less extreme than mania. So you could have real happy days, real sad days, more talkative, more crying, just different things that goes on and on inside your family or your loved ones. Anxiety disorders can include symptoms such as excessive fear or behavioral disturbances. They can interfere with your daily activities, but treatment can help. There are many types of anxiety disorders that can be diagnosed by mental health professionals, including separation anxiety, phobia, social anxiety, panic disorders, and even generalized anxiety disorder. Schizophrenia is one mental health illness in the category of schizophrenia spectrum, and other psychotic disorders, all with the following key features of psychotic episodes: delusions, hallucinations, even negative symptoms, diminished emotional expression. In serious emotional disturbances, not every person with one of the following diagnoses qualifies with an SED. When children are dealing with different things in their life, whether it could be trauma from their home, different things that might be going on in their school, and the child comes to someone or they're talking to their parent, they talk about different things, and you say, well, what is going on with you? As a parent, if you sit down and say, hey, how was your day? What is going on with you today? What happened at school today? Did you like your teacher? How's your friends doing? And then you start talking to them about different things that might have went on. That's when you start finding, oh, well, the baby might be depressed, or the child might be depressed, or they might be having some trauma or stress-related disorders going on, or oppositional defiant disorder. And that's when you could get them to where, okay, well, let's take them to where they can get some more intensive therapy, and let's get them where they can talk to someone, where as a family member, you're not the person that they're going to somebody on mutual ground. So serious emotional disturbance can affect an individual in areas beyond the emotional, depending on specific mental disorder involved. A person's physical, social, and cognitive skills may also be affected to the point that it interferes with the functioning of home, school, and even their community. So, trauma and stress-related disorders, PTSD, even in kids that might have been in a situation where mom was a part of domestic violence, or where different things where they might have been in a foster care system, or different things have gone on in their life, even a car accident or something that they don't even know how to explain, a flood, tornadoes when we live in Oklahoma, where kids need to talk about stuff like that. And you start to think about, well, what does the kid, what are they dealing with? They get angry, they get aggressive. Uh, and the combination of all these symptoms is where the types of trauma and stress related disorders would come in. OCD, or obsessive compulsive disorder, is where obsessive compulsive disorder includes time consuming obsession compulsion, or both, that are not attributable to substance use or the mental health or physical condition. Obsession, recurrent or persistent thoughts, urges, or images experienced as intrusive and unwanted, usually causing marked anxiety and distress. Attempt to ignore, suppress, neutralize these with another action. Compulsions are defined by both repetitive behaviors or mental acts that someone feels driven to perform in response to an obsession or according to a rigid rule. These behaviors are aimed at preventing or reducing anxiety, distress, or a dreaded event situation, but are not connected realistically to the obsession or are excessive. Oppositional defiant disorder in children is when they get angry, they get irritable, their mood changes, they often lose their temper, often touchy, easily annoyed, often angry, resentful. Argumentative defiant behavior often argues with authority figures for children, adults, often actively defies, refuses to comply with rules, requests from authority figures, often deliberately annoys others, often blames others for mistakes and behaviors. And when we said, and we talk about this in kids, and you see them and working in the school systems and stuff like I do, you can see where the kids come in and they're really upset and they're really mad and they say, oh, it's oppositional defiant disorder. And when their pattern of behavior that lasts more than 6 months and is evidence based by at least 4 systems from this, you can say, okay, well, it could be oppositional defiant disorder. But if it's not, that's where the family can do early intervention and could prevent a crisis that is fixing to come into their home. And when you step in as a family member, even if you're an aunt, an uncle, even a neighbor, that where you're going to step in for your little neighbor kid, or as an adult neighbor, and you're saying, okay, I'm here to listen to you, I'm here to help you. And as a community or your neighborhood, where you start to come together and you listen and you start to divert that crisis. That was about what I had for my presentation. I am here with some resources. There's QR codes for that. I would like to, you can click on the Oklahoma Department of Mental Health for more resources here. Also, our QR code is here for LIFT and Parents Helping Parents. I am the president of the Parents Helping Parents here in Oklahoma, and what that is we reach out to families that has children or loved ones that is in addiction, and they need someone. And if you just need someone to talk to, if you need someone to reach out to, you can reach out to us anonymously. And we are based here in Oklahoma, and it is a free resource for families that is needing someone. Like I said, Oklahoma Department of Mental Health has lots of things that they can offer you, and so does LIFT if you're ever in southeastern Oklahoma. But one thing I want to add, if you have someone that is dealing with a crisis and you don't know where to turn, remember 988. That is confidential. You can text or you can call. And that is a good resource nationwide. And when I present that to the people and they come and talk to us and they say, no, I'm not calling 988, it's like 911. No, it's not. It is confidential. They will connect you with someone that you can speak to. I want to thank you for listening to my presentation today. And always remember, never give up on someone with mental illness. When the I is replaced with we, illness becomes wellness. Thank you.
All right, thank you, Susan, for that great presentation. My name is Sheamekah Williams. I'm the president and CEO of the Evolution Foundation out of the state of Oklahoma, based out of the city of Edmond. The Evolution Foundation is a statewide organization that provides community technical assistance, training, and advocacy for children, youth, and families across the state of Oklahoma. In addition to that, I am a former director of Children, Youth, and Family Services for the State Department of Mental Health and Substance Abuse Services out of here in the state of Oklahoma, where I also was the lead developer and designer for the Children's Mobile Response and Stabilization System. And so that is who I am as a person, providing subject matter expert to University of Connecticut across multiple states, where MRSS is the customized model for children and families. So today I'm going to talk about coordinating with 988 in order to increase access for SMI and SCD individuals who need treatment for crisis care. The objective for today is one, to the importance of a single access point to support loved ones who are SCD or SMI, who need access to immediate care. I'm going to talk about the difference in calls related to children youth, as well as adults, the uniqueness of a customized children's crisis system compared to traditional care for mobile crisis and mobile response services. And then I'm going to also share some implementation strategies and ways to really coordinate with 988, whether it's your 988 team, your crisis staff, in order to serve youth and adults and your loved ones with SMI and SCD. The first thing I'm going to talk about, I think this is an most important part of the conversation, and oftentimes getting help can be very difficult for individuals with SMI or SCD. I think that prior to SAMHSA's implementation of 988, when you were looking for crisis services in any state, the most utilized resource was our emergency rooms. I think that we as Americans have been trained to use 911 and emergency rooms for mental health care. I think the reason why those things have been established is because we all know when you call 911, you're going to get police, fire, or medical, but you're going to get some help from one of those individuals. And so thinking about the medical system and thinking about the emergency response system, I think it's important for both states and providers to consider when in fact families or individuals need help, they need help now. And so really, again, kudos to SAMHSA for designing the 988 single access point, because 988 should be the single access point for any individual, this like 911 is the access point for emergencies. And so really working with your 988 system is critical. 988 should be the entity that no matter where you are, no matter if you're in rural parts of the state, no matter if you're in another state, I think that should all be the 988 should be the point of contact when you're in a mental health emergency. In addition to that, I think that really working with your crisis system, both at the state and the local level, and your crisis team providers to really understand and to be able to address the sense of urgency. As I mentioned, I'm the president and CEO of the Evolution Foundation, but I'm also a caregiver, as well as a parent of youth and young adults, as well as I've been a caregiver for an adult who has severe mental illness. And so really when we think about the urgencies that come out of crisis situations, I think it's important to understand that when in fact we want help, we need help now. Because what stats will tell you, if we don't get the help that we need from the 988 system, what happens? emergency room boarding happens. And so in order to divert away from emergency room boarding and in order to make sure that families and young people receive the help that they need, we have to show up. There's not an option for us not to show up. And so the importance of that is really thinking about the types of calls and the types of individuals that will be needing the support from the crisis center. When we think about youth and young adults, oftentimes, as Linda mentioned earlier in our slide, she mentioned crisis can be defined as a stress, emotional, or behavioral symptoms. And so most of us understand that sometimes stress can be so overloading and outweigh the situation to the point that we need help. We don't often have the range of resources or supports in order to stabilize the situation. And so my belief is that individuals who call our crisis line should be able to articulate or dictate their crisis need or their crisis concern. And we should be able to create systems that show up for us when in fact we need them in a timely manner. As SAMHSA will again define, basically, SAMHSA talks about in their core principles around someone to talk to. And they have created a 988 nationwide number where individuals can call in order to receive someone to talk to, someone to respond, whether we're talking about youth or whether we're talking about adults. Mobile response or mobile response and stabilization or mobile crisis system, mobile community models have been developed all over the nation for the purpose of responding to individuals in crisis. A safe place for help. I think that safe place for help oftentimes can be community partnerships within the community that provides opportunities for respite for youth and young adults. Safe places can mean places where individuals can stabilize out and get back to their norm without harming self or harming others. So really looking at how do we create an opportunity for individuals to respond, for someone to talk to, someone to respond, and how do we create safe places and environments for individuals? And then also the importance of community. When I look at this figure, really creating a unified principles to achieve effective crisis and mental health services, it takes a village to do this. And I think when we think about the It Takes a Village model, we think about opportunities to engage community, to partner with communities across the spectrum, to make sure that we're providing services that are trauma-informed and accessible to individuals who need us. There's a perspective approach and partnership. And really, how do you partner with the Office of Juvenile Affairs or the Child Welfare System or the individuals that provide older adult mental health services? How do you partner with your community platform, your healthcare providers, your emergency room, in order to be the aid that really actually works to prevent, intervene, and provide treatment for individuals with mental health services? And I think the most important, as I mentioned, it takes a village. I think the most important is how do you begin to partner with communities across your state, across your service area, to make sure that folks understand the crisis system and the services and the supports are available, helping them to understand the signs and symptoms, as Susie mentioned, as Terry mentioned, helping them to understand the signs and symptoms of mental health, so that when in fact they come across an individual that has high stress, emotional, behavioral symptoms, they're able to understand what that is in order to intervene and get help for those individuals as quickly as possible. How do we create that unified system? I think it's also important to create pathways to care. As I mentioned, how do we create that system? It's about creating those pathways. It's about working in your urban and your rural communities and even your frontier communities to partner across areas, to partner across tribes, to help people to really understand the importance of crisis. It's about providing that community education. When in doubt, who do you call? When you need help, who do you call? When you need access to treatment services and supports and it's not a crisis, who do you call? How do you partner with schools in order to be able to maintain kids in the classroom, or in order to look at opportunities for kids not to be expulsion, or, kicked out of school? How do you make sure that our kids with mental health and substance abuse challenges are able to maintain in school environments? How do you work with kids that are in custody? Oftentimes kids that are in custody have the more higher rates of trauma than other kids that are served in the mental health system? How do we create pathway to kids that are in custody that need access to behavioral health challenges, or also who need access to a crisis system? This would also include all your other child serving agencies. What is your partnership with emergency responders? What if SAMHSA shows up to a mental health crisis? How does SAMHSA connect with your crisis system in order to make sure those individuals get the types of supports they need? How do you work with young families that have kids 0 to 5 or kids that are IDDD? What did that family support need to look like within your crisis system? How do we make sure that individuals who are adults that may be living with a caregiver, maybe it's a mom who's trying to care for her um, teenage son that has a mental illness, or maybe it's an older elder mom who's trying to care for her adult child that has a severe mental illness. What does that look like? What does that look like? Oftentimes, we look at opportunities within our system to really help to redefine and to really help to make sure that we're providing access to the supports and the resources and the things that people need. But oftentimes, we forget about categories of individuals who need us the most, like elder parents who are trying to care for their older adults who have a mental illness. And oftentimes we know that those situations can sometimes turn bad and sometimes turn violent. And so how do we make sure that we're reaching that population of people to say, we have a system that can support you and provide you the resources that you need in order to be a supporting caregiver to your child? So what do those pathways need to look like? What we know is we're trying to transfer from this confused system where individuals are calling 911 or they're going to the emergency room for help or they don't know who to call for help, to a customized pathway system where there's a single access point where people can be driven and gone in the same direction in order to get to the place or the point of help that they need. And so really think about what that looks like for your state, what that looks like for your county, or really what that looks like for a system. Is it still blurred in confusion? Or have you done the work to create the pathway, no matter who calls your 988 line or no matter who calls your crisis line, that people will gain access to the supports and the resources that they need? Really important. I think it's also important to really think about upscale interventions. How do you create administrative structure, oversight, and policies that allow families and allow adults to receive pre-crisis services prior to it blowing up? And I think oftentimes we have the warnings, we have the signs that something is going on with our youth and young adults. Maybe they're not going to school like they're supposed to. Maybe they're not participating in family functions as they normally have. Maybe they suffered a loss of a loved one, and that's pretty difficult to get over. How do you make sure that we have some upstream interventions where we're able to aid those individuals early? How do we make sure that those individuals that are on our most in needs list when it comes to mental health services across the nation, these individuals have been in and out of crisis hospitals, they've been in and out of hospitalization. How do we make sure that we connect to let those individuals know that we have the ability to provide upstream opportunities for them to receive treatment services and supports that will oftentimes prevent the elevation of crisis? But then also, what is the point of intervention when in fact you're on a spectrum between you're just right at that point of crisis or you're at a full-blown crisis? Who do people call? And again, 988 being the single point of access line for behavioral health services across the nation. That is the line that most of us will need to call. It is important for 988 and important for crisis providers to understand the sense of urgency when people call. When I call, I need help. I don't need to be diverted. I don't need to be scheduled an appointment. I need someone to talk to now to help me to understand what options I have available for myself or for my youth and young adult. How do we make sure that people who contact the 988 line really receives what they need to receive in order to prevent them from turning around a few hours later or the next day and showing up in an emergency room? Because you can best to believe if I don't get what I want, when I call for help, if I don't get help now, like most Americans, I'm going to go to the emergency room because I know if I can get my young person there, they're definitely going to be in a much safe place. And I don't have the knowledge or the understanding to know what's really going on. And so you try to get your youth, young adult or adult to a place where they can help you. And so how do we make sure we're showing up when there is a family sense of urgency? And how do we make sure that we're shifting and creating pathways for higher intensive services? And how do we make sure that we are creating opportunities to provide alternatives to crisis services? And how do we make sure that we're providing alternatives like stabilization supports? How do we make sure that we're, looking at opportunities for, young people or adults to get their medications monitored? How do we create those opportunities? And I think it's really about not just providing the crisis services and responding in an emergency situation, but we need to, not only do we need to respond, we need to look for opportunities to stabilize. I think it's also important for crisis to recognize the natural intervention points, roles of crisis service providers within the broader behavioral health system echo. I think that behavioral health is not within a vacuum. And I think there's oftentimes supporting community partners, supporting providers that are natural intervention points, where oftentimes when signs and symptoms come up, how can we intervene as early as possible at those natural supports? How do we make sure that the community, public, child serving providers and adult providers really understand the signs and symptoms of mental health? How do they understand what an onset look like, or sometimes how stress can unresolved stress can lead into chronic symptoms, chronic mental health systems? So how do we provide that education to the broader network of community partners? And then also recognize the healing potential within the community. I think it's really important. Community connections are extremely important for individuals who have a mental health disorder. And so how do we make sure that we're connecting people back to their community, maintaining engagement with their community, and really creating this opportunity based on what it looks like for them? Not everybody belongs to the local YMCA. Not everybody belongs to a faith-based community. But how do we work with individuals to create the types of community connections that can be extremely important to them? And so really connecting with your community. And then also recognizing, higher intensive service can be trauma induced and trauma informed. So really utilize effective strategies, creating mobile response and stabilization opportunities to customize systems, utilizing the systems of care values and principles as an alternative to really understanding how to care for individuals that are in need of higher levels of care, or to understand how to develop a system model that works for children, youth, and families. Some of the recommendations, and I want to give I have the honor and the pleasure of working with the University of Connecticut team, both Liz Manley and Tim Marshall. And I think the reason why this was important, because as we were developing the state of Oklahoma's Children's Mobile Response and Stabilization System, there were some critical factors that were taken into consideration as to how that system in this time of 988 can really move into a direction where that single point of access can provide the support to both children, youth, and families, and not just for adults who are in crisis. So really state leaders really to work on integrating 988 and mobile response or mobile response teams is important. There are many states where you have multiple mobile crisis providers or MRSS teams within the state. How does 988 make sure that those teams are integrated within the system, so that if an individual calls from a county where there's an MRSS team available, then that MRSS provider is contacted to provide that stabilization services? Or if an individual call and there is a crisis team in a county that's in a nearby county, or there's multiple crisis teams, how do we make sure that those calls are going to be routed to the most appropriate provider? So how do states utilize 988 as a single point access for multiple teams that may be aligned within the state? The reality as a caregiver, as a parent, I know I know in the county that I stay in how to contact the provider, but what if I'm in another state? What if I'm in another county? How do I make sure that there's one single access point, so that we don't have to remember multiple numbers across the area, or we don't have to We don't have to necessarily search for numbers or Google numbers for the importance of getting our crisis care. How do we utilize 988 to be accessible to all crisis units across the state? And I think that comes with providing, again, customized training, practice, and a workflow that can be valued for the needed population. So really working in partnership with 988 in order to make sure that not just 988, but crisis providers across the spectrum really have practices in place and a workflow in place, and where there's an understanding between your 988 system and your crisis system. So developing policies and procedures for 988 that acknowledge unique needs across the lifespan for individuals with SMI or SED. Offer developmentally informed approaches. Again, how do we make sure that youth, young adults, and their families receive 988 services or receive services through the 988 call system that are developmentally appropriate? How do we make sure that there is a value alignment with the systems of care values and principles that is really about families and for families? How do we make sure that both systems really have an understanding of that? Mobile response and stabilization with mobile crisis team members trained in adolescent child development, family system, and other related topics. How do we make sure the responders are educated in the appropriateness of the type of response they're going to provide based on the age of the youth and young adult? How do we make sure the youth and family peers are a part of that process? I think that oftentimes we leave out youth and family peers as a part of the crisis system. Again, one of the most important elements is that oftentimes when you have peer support in a crisis system, they've been through this situation before, and they can offer the caring adult, the caregiver, they can offer the types of support that can really help to stabilize that person. Because most of you guys know when you have an individual or person in crisis, in many cases, when they're aligned with the family, that entire family is in crisis. So how do we utilize our peer specialists, not just to support the individuals in crisis, but in order to support the caregivers and the parents that oftentimes are in disarray because of the crisis? And I also think cross-agency and community-based organizational collaboration. You know, again, adults as well as young people go into crisis from various sorts and various places. You know, how do we use peer supports in order to provide the education to those adult systems so that they understand whether you have an elder adult, whether you have a adult who's at a transition age, or whether you have adult that's in the middle age? How do you make sure, whether you're a working adult, you're a homeless adult, or whether you, no matter your situation, how do we make sure that there is agency training and opportunities to collaborate and partner with those entities? And then as well as the older adults, I think oftentimes we leave out the older population, not recognizing that with today's stressors, older adults have situations where behavioral health concerns or symptoms can be problematic. Making sure that individuals are trained in areas of health-related trainings that would actually help you to identify similar patterns such as dementia, help you to identify situations that may be abuse and neglect for an older person that you may respond to, helping you to identify the signs and the symptoms that would actually say this person needs additional supports or services beyond just the crisis care, because this is not a mental health issue. This is an issue that is related to a healthcare need, or this is an issue related to abuse or neglect. So how do you make sure staff are trained to understand that? I think it's also important to really think about our ability to provide rapid face-to-face and really develop appropriate assessments and response for children and their families. The reason why this is important, because I think that in many cases, we utilize a system that really works to divert situations of crisis. And when in fact you divert it, the hope is that those individuals show up at a community mental health center or CCBAC or a private mental health provider for follow-up services, but we don't often know. And so I really think it's important to look at opportunities to engage face-to-face. When a person feels like they're in crisis, sometimes the presence of another individual can be calming and soothing. And oftentimes as a caregiver myself, the presence of another individual helping me to work through what needs to happen next helping me to understand that when in fact that my young person or my older sibling has to go into a hospitalization, what does that mean for me? And so I think that rapid ability to provide a face-to-face response creates an environment where individuals are able to process the information better because they have someone walking them through the process. They're really able to prioritize the services in a way that they have a much clearer and a better understanding. So really look at opportunities to do face-to-face options. Diversion practices are great, but they're not always the best because oftentimes when you divert an individual from a system, they come back up in the system. And so if we're able to intervene early, as quickly as possible, maybe we're able to divert that crisis and derail that crisis in a way where the person can get the help and the support that they need, where they don't go back into crisis within a 24-hour, 72-hour window. And then also, I think the face-to-face option creates an opportunity for a whole family approach, really avoiding unnecessarily inappropriate involvement in the child welfare system. One of the oftentimes that when in fact families are not aided at the time that they need aided, things can happen. And sometimes kids can often end up in the child welfare system because caregivers or families get overwhelmed, exhausted, and then again, and sometimes in some of those episodes, abuse and neglect can come in. So how do you begin to do that? And then also, how do you begin to really think about responding to situations where not necessarily law enforcement is needed? I think that's a situation where working with 988 for a customized deployment, where as a caregiver, I have the ability to say, this situation is safe. I don't need law enforcement. I feel like I have the situation safe. Or when you have opportunities to train your law enforcement officers for the purpose of creating that safe environment so that you can move in as a mobile responder to aid that family is really important. What do those mutual responses look like? What is the role of law enforcement in a mental health response? And what is the role of the mental health provider? So really partnering with entities that provide that option. And then I think it's also really gathering data and call volume, response times, user satisfactory and outcomes to really create that quality improvement. That's how our 988 or our crisis systems are going to get better. If we're able to collect the data that tells the story of really what's happening on the ground, really can help us to generate the ability to customize a little better, to provide quicker, faster services, and to uniquely support children, youth, and families at a greater way. And I think also it's important really allowing you, young people, loved ones with SMI and their caregivers to define their own crosses. I mentioned this to you earlier today. I think it's really sad when in fact I come across caregivers or older parents who talk about the fact that they need help for their youth and young adult or their youth and young adult or their adult. And oftentimes situations should not have to rise to a level of crisis for a system to intervene and provide support. Because oftentimes how you see a crisis and how you visually observe a crisis or how you articulate a crisis or what you think about a crisis may be completely different from how I see my crisis and how I see my situation. And sometimes a crisis in a family is that adult caregiver is exhausted and she don't know where to turn, who can get help. And so sometimes those situations lead to an increase in behavior in the young people. And so if I'm able to say I am in crisis and maybe it is my crisis as the caregiver because I'm exhausted, I should be able to get the help that I need at that particular time so that we can divert away from further behavior health escalated crisis with symptoms and psychosis that often lead to higher levels of hospitalization, kids in out-of-home placement, adults that are in acute settings. Again, we want to look for opportunities to aid people when they need it, because what we will be able to do is change the way that our crisis systems are often overwhelmed with ED boarding or overwhelmed with high levels of youth and young adults and inpatient care. So aiding people when they need to be aided as early as possible creates that opportunity. And then the last thing is really educating providers, young people, loved ones. Again, Mobile response and stabilization is a customized model that is customized based on the needs of the youth and families. And I think that's the important thing. When you customize a system, you want to customize it based upon what the individuals that are going to be served in that system need. It's not about customizing it to a billing performance. It's not about customizing it to the needs that I have as a worker in the mental health setting. It's really about creating a system that is best utilized for needs of families. So really think about some of the bullet points. MRSS dispatch to mobile rather than law enforcement. I think that is some of the recommendations in really looking at customization and how to be able to keep people safe. Mobile response and stabilization believes that most people who are SMI and SED can be kept safe in a natural environment, again, in their home and in their community. I do believe that. I think that when we provide early and immediate interventions, we're able to do that, keep people at home and in the community away from higher levels of care. And so, again, really think about what does customization look like for you, for your community, for the people you serve, and how do you create a system that really looks like that? And the mobile response and stabilization model is one way to look at customization for youth and families, but it can also work extremely well for adults. Again, I think it's really important, as I brag about this oftentimes. Oklahoma designed our model off the backs of Jersey and Connecticut. And I think it was really important for us to customize it in a completely different way because we were a ruling frontier state. And so really, think about some of the assets that Jersey and Connecticut have paved the way in many cases. One of the things in Jersey is to connect 988 to MRSS allows streamless communication and dispatch within Jersey. They've created a system that allows 988 to dispatch to the Jersey mobile response and stabilization providers, creating a streamless communication and an upscale intervention. I think also some of the important things to think about. How do you make sure that service providers are utilizing caller ID? How do you look at GPS technology? Some states have text, chat, and video lines. How do you, again, look at your call centers in a way where they're inclusive to all types? What if you have an individual that is nonverbal? How can you make sure that you're communicating? What if you have an individual that's Spanish speaking? How do you make sure? And then also the opportunity for real-time regional bed registration. And not just regional bed registration, but the ability real-time to schedule appointments with providers in a real-time opportunity. How do you make sure if walk-in appointments are not available, you're able to schedule? How do you use technology in order to do face-to-face for a person that may be needing face-to-face? So these are some technology things or some things to really think about. How do you really work to robustly improve and build your system so that it can be inclusive to any and everybody? Again, as I mentioned earlier today, I think Linda started it off in her presentation by talking about the importance of us understanding crises are defined as stressful situations, emotional, behavioral symptoms that an individual may be having or experiencing. And so I think that when you look at the fact that stress is at a high point nationally across the nation, we definitely need to make sure that we're creating a customized system that has the ability to respond to any and everyone at any point. Because I can promise you, if we're not responding, then people will utilize 911 emergency rooms for their mental health needs. And so again, thank you guys for listening to me today and really talking about the importance of a customized system, importance of working with your 988 partners in order to work with your community partners in order to make sure that we create a crisis system that exists for all of us. Thank you. All right, Melinda, I will turn it over to you.
Thank you so much. I don't know about y'all, but before I get started and even introduce myself, let's just all take a breath. We have heard a lot of information. We've been staring at the computer for, about an hour now. So I think just taking a minute and checking in with ourselves is always a good thing. So I too want to show my gratitude for being here and being asked asked to speak. A little bit about who I am. So again, my name is Melinda Brummett. I use she, her, hers pronouns. I'm white and Chickasaw, and I am a family support specialist, and I'm a family support specialist trainer and a peer coach. And what brings me to this work is I'm a mom of 4, ranging from 27 to 22 today. My baby turns 22 today. And I've been living this world for about 23 years when my 27-year-old was diagnosed with some pretty severe diagnosis. And that sent our family on a journey of trying to figure out how to navigate all of this. And so my presentation today really does come from my lived experience. OFSN, Oregon Family Support Network, as an organization in Oregon, comes from the lens of families that have walked this walk. And every single person who works for the organization is a parent and a caregiver of somebody who struggles with behavioral health or mental health. And so my personal story and journey is one of crisis. We have lived in and out of crisis. Of my 27-year-old, the first time that he talked about suicide, the first time that he attempted, he was in 2nd grade. And so this has been a journey for us. And so this is extremely personal and passionate for me. And so that's a little bit about who I am and what brings me into this. I've worked for OFSN for a decade now. For that, I have supported families in peer support for roughly 20 years. So this is something I'm very, very passionate about. I also want to say and acknowledge this is a training talking about crisis stabilization versus crisis planning, moving into crisis planning, which is really thinking ahead of the crisis. This is a training that I normally do in 6 hours, and I'm shortening it to 20 minutes. So we're really going to be hitting the high notes, but please know if you have any questions or you would like to talk further about this subject or how to do a family-led crisis plan, please feel free to reach out to me. I'm going to put in a few minutes, I'll put my email in the chat. I am always available if you would like to reach out and kind of go over this in some more in depth than I'm able to do today. And again, I've seen the chat in here several times. Please put your questions in, and we're going to try to have some time to answer those. So put those in the chat. We have wonderful people who are gathering those for all of us, and we'll try to get to some of that. So we've spent our morning talking a lot about the diagnoses and what a crisis is. We've spent some time talking about the structure from an state and local level and really kind of getting that in line. And I'm so thankful for all of those things. And it is about how do we know what a crisis is and how do we stabilize when a crisis has occurred. Crisis planning and family-led crisis planning is really looking upstream. We're wanting to have these conversations long before a crisis happens. And we're really looking at how can a family look at every individual of the family, all of the nuances of the family, and really create a plan that can help interrupt the cycle of crisis as it's starting in its earliest stage. And we also need to recognize the importance of the professional team and of kind of this larger cycle of what to do when that crisis happens, that we have this continuum of care in the moment, right? And so I want to thank everything that was said before, because it really did highlight the importance of how do we really create this continuum of care when we're responding in crisis. And what can families do before? Because when we think about crisis stabilization, it really is reactive. It is something happened, there was behavior, there was something that was being communicated, and we need to react quickly so that we can create a safety and a reduction of what's going on right now, so that then we can increase safety. And oftentimes when that happens, we need professional supports, whether that's through 988 or the mobile response team or the therapist, crisis center. We need it in that moment. But what we want to think about when we're thinking about family-led crisis planning is doing something different. How can we be proactive before any of that happens? How can we engage the whole family? And when I say whole family, that really is defined by the family. Who's the chosen family? If you were to ask my family who our whole family is, there would be all of a sudden names of our 4 dogs, because they are part of our family and we utilize them in our crisis planning. I'm going to talk a little bit about how later, but absolutely our pets get utilized into our crisis planning. It is everybody that is in the family. And right now we are in a season where all 4 of my adult children live at home, including one of them has brought their partner. And so it's changed, and our crisis plan has evolved as our children have grown. My husband also struggles with mental health. And so we really think about the whole family. And when one person's in a crisis, it really is the whole family is in that crisis. And so we're going to have a very different conversation. We want to identify activations and signs and symptoms. We want to make sure that we're building and using those protective factors as strategies for not just the crisis, but as strategies for those activations and those signs. We talk a lot about we're going to build on the strengths of the individual, of the family, and of our community. And so those strengths that every single one of us have, no matter what diagnosis you have, you still also have an abundance of strengths. And sometimes your diagnosis is a strength. And so we really want to use all of those as building protective factors for the family, identified with the family, with the family. And so really, as we move on, what we're saying is we need both. We need to have reactive plans. We need to have functional systems in place on our state level, our national level, our local level, our school level, on our community level, on every level. We need to have reactive plans that work for families and the community. And we need to have proactive plans that the families can really own, and that the families can say, you know, I know what to do before I call 988. I know things and strategies that we can use before we ever need to get to that place. Or I've done all of that. I've used all of those strategies, and we're still in crisis. And now I can move into these things and not feel shame, not feel guilt, not feel like I did something wrong as a parent. These proactive plans are embedded, these reactive plans are embedded in my proactive plan. Because what we know and what families have told us, what I have personally experienced, is that when I utilize system reactive plans, I end up feeling guilt and shame that I did something wrong as a parent, when all I'm trying to do is get help. And we have those in place. So why do I feel guilty when I use it? And oftentimes families have been made to feel, when they're utilizing the reactive plans of the system, that, oh yes, you got here because you did something wrong. And so we want to say it's a balance. Both are needed. We can't just talk about one. We have to talk about both. So here's a little example quickly of a family-led crisis plan conversation. And so really this conversation, and really a family-led crisis plan is more of a conversation, needs to happen when a family is calm, when there's not a crisis, and not immediately following a crisis, right? We want this to be when we are in our most calm state. And we have conversations where we want to really look at, what does this emotional state look like? Not naming the behavior, but instead really trying to articulate, what does this look and feel like? So when I'm at baseline, what does baseline look like? So that I can recognize it when I see it, right? I'm not thinking about, what do you do when you're at baseline? What does baseline look like for you? So for me, I always say, for me, my baseline is from the moment I wake up to the 20 minutes before I have my cup of coffee. I'm on automatic pilot. Then I have a cup of coffee, and now maybe I'm a little above baseline. I'm actually now able to articulate. I can probably hear things a little bit better. And I'm going to talk about that, and I'm going to describe what it looks like. It looks like I can carry on a conversation. It looks like I'm actually realizing there's other people around. It looks like maybe I'm humming a little song, or maybe, I'm walking around and not stomping. And I'm going to describe, right? And then I'm going to move to, as my day goes on and I stub my toe. That's a thing that happened. But it created an activation. It had me feel in some sort of way. I'm going to describe what that looks like, right? And we can do that with every member of the family. So you're going through your day, what might be something that kind of aggravates you, or that just kind of gets you kind of holding your breath for a minute, makes you a little bit tense, or you kind of roll your eyes? What does that look like? Again, we're not talking about what behavior are you doing and exhibiting. We're talking about, what does it look like? Because if we just look at what behavior creates an activation, that behavior could change tomorrow. Maybe it's a stubbed toe today. Tomorrow it's, I spilled my coffee. And I need to know what it looks like so that other people can know what it looks like. And then we're going to have a discussion around, what strengths, what strategies, when you stub your toe or spill your coffee, or your sibling snaps at you, or your alarm doesn't go off. What strategies do you use that help calm you back down? What strategies, what strengths do you have within you that help regulate you? And we're going to write that down. We're going to describe that. And so we continue to do this all the way up, right? So you tried that, activation, maybe you calm down for a minute, and then I stubbed my toe, I spilt my coffee, and now my car won't start. Thing on thing on thing is building, right? And that's what happens with families so often. Making lunch, and my son wants peanut butter and jelly, and all I have is bologna. And that's fine for me, but all of a sudden he's really irritated. And now he gets on the bus, and where he wants to sit, somebody's there, and he has to go sit somewhere else. And now that aggravates him, right? These things build. And those things change from day to day. So we don't necessarily focus on what the thing is. Instead, we want to focus on, what does it look like? What does it feel like? And what things do you do when that happens? We want to get our kids involved in this, our youth involved in this. So what happens when you can't sit where you want to sit, and you have to try to calm down, and your youth says, I look over and I see my friend Sally that's sitting over here, and I kind of give her the look, and she looks at me like, yeah, I know, sorry you couldn't sit there. And I'm like, wow, that's a strength. You communicate with somebody who gets you. And I want to praise and prize that strength and say, okay, let's build strategies. on that. So we're going to do that all the way up, right? And again, we might on this chart with a family have some behaviors, but really what we're focusing on is trying to help every member of the family talk about what does it look like? What does it look like to regulate? What does it look like when you get activated? What does it look like when multiple activations happen? What strengths do we use? What does it look like when those strategies aren't working? Right? So the goal is that hopefully we can have filled this chart with so many strengths and so many strategies utilizing our friends, our community, our other members of our family, our dogs, our pets, to come in as strategies to help regulate. And we use that to then build interruptions. So hopefully we don't get all the way up to a crisis. But we also know we live in a real world. And sometimes we do get to that crisis point. And what we want to say is, man, you used all of these strengths. You used all these strategies. That was phenomenal. And you have a strength and a strategy of utilizing the professional systems, using 988, using the mobile response team, using your therapist, using that crisis plan. We want to normalize that and say that's just part of this plan. Those are the strengths and the strategies of your community and of the bigger support factors. So we're going to use them when we need to. And then hopefully we have more days that we're able to utilize our strengths and our strategies to interrupt it than days that we have with full-blown crisis. That's the ultimate goal. Oops, there we go. So what are some things that can really help us as family members in creating these plans? Well, we know peers play a big part of that, and family support specialists play a huge role in that because they bring that parent lived experience. They bring that, they know what it's like to be in crisis. They know what it's like to sit in the ER, right? And I mean, I would tell families all the time, because I would meet them in the ER when I would get called. And usually my first meeting with them is sitting in the ER. And I would come with a drink and say, you know, I brought you this because I've had this coffee. I know what this coffee tastes like in this room. I have been sitting here, and I just wanted to bring you a fresh cup of coffee or a fresh, cup of tea or whatever that might be. Or maybe I realize I got the call a couple hours ago, and I know this family's been there for several hours, and I'm going to bring a sandwich because I know what it's like to sit in this waiting room. So peers bring that. We know what it's like to sit in that space. And when we can express that strategically and appropriately, it builds support and empowerment, collaboration, and trust. We understand the language of the professionals, and we understand what it's like to be this family member in crisis. And so, because we bring that lived experience, we really can help families articulate and look at crisis in a different way. We can really start using our lived experience and really the importance of something being family-led and creating this bridge between systems and families, normalizing crises, normalizing the need for a safety plan or a crisis, a family-led crisis plan. But we can normalize that. We can say, yeah, there's nothing wrong with your family's not broken because you need this. Your family is your family. My family is my family. This is something that's been helpful. And I get it, right? And so family support specialists bring that experience of we've been here, we've done it. And we also know that there's going to be a lot of professionals that also have lived experience. And one of the unique things about a family peer support is that we are required to bring that lived experience versus other people don't have to bring their lived experience, and for good reason. For them to keep doing what they're doing every day, they need to be able to kind of have some walls. But as a family support specialist, I'm going to bring my experience of sitting in these ERs. I'm going to bring my experience of working within crisis plans. But the reality is that before I learned about this, that my family had multiple crisis plans that systems had created for us, wonderful, caring systems had put together beautiful safety plans that fit all of their system requirements. They were pieces of paper in a drawer for my family. That's what they were. And so we weren't asking or looking at who should be there, what was in, what did my family look like? And so really identifying who needs to be in the conversation and realizing that we want to engage the whole family and who the family wants to be is so important. Again, I'm going to kind of move through this really fast. So some identifying strategies and having these types of conversations is, what's worked, what hasn't worked, who's helped, who makes you feel good, who maybe isn't helpful in a crisis, what have you tried before. The important thing is that we realize we don't want families to feel judged or blamed. We want to make sure that the family can ask for the services and the supports that they need, that they have a sense of dignity, and that they feel validated and valued. And the whys, we know the whys, right? Safety plans need to work for the families. And right now, so often safety plans work for the system. But a family-led crisis plan is something that is going to work for the families. So I just wanted to show this. This is an example of one that I did with a family where we did this with this youth was under the age of 10, was very involved in the process. Some of the things that I think we identified, where does this person feel unsafe? We identified what does it look like? Then we came up with some strategies. With that, some of the things that I really appreciate about this that I wanted to just highlight is that when we created this, and for them it's a big poster board that's in their house, and the school has the one for the school and so on, but that the youth identified that one of the things that was challenging for him was when they were at the park and mom was on the phone. And so he got to say one thing that's helpful is if mom doesn't have her phone with her. And instead, what we said is, what if mom had a friend with her? That gave support for mom. And it also had, usually mom would bring their kid, and it created another youth for this youth to play with at the park, right? So really creating some tools and some toolbox for the, for the family, for the youth. So again, here's just an example of what it looks like when we've done this. And then kind of lastly, I just want to really iterate that every family has their way of doing things, their customs, their culture, their language. And we want to make sure that when we're building with them a family-led crisis plan, that we are utilizing all of their culture, all of their lived experience, all of their strengths, their language, all of everything that's important to them, their values. Because what we know is that when a youth or a family is in crisis, all of that's going to be on display. And we want people to see the strengths of those and not the challenges of those. So we want to really utilize all the beautifulness that is a human soul and a human being and their way of being. And we want to really utilize the strengths in a family-led crisis plan. And lastly, we just want to identify what is most important to the family. What does the family want known and seen? And we want to make sure that gets utilized in the crisis and safety plan that's family-led. And with that, I'm going to turn it back over for, I think we have like 10 minutes of questions.
Yes, thank you so, so much, Melinda, Sheamekah, and Susan. This was great to have 3 different perspectives on that continuum of crisis care. The first question we have, I'm going to direct to Melinda because it was asked during her presentation. The information that you presented about family-led crisis planning sounded a lot like the WRAP program to Belinda. Can you clarify a little bit what is different between what you were presenting and the WRAP program?
Yeah, so Wraparound is a process that families utilize across the nation of really identifying needs and strengths and how do they build a plan to meet their needs. And really, it's about giving them skill sets that would follow them long after one or two identified needs. Within Wraparound, there is a safety planning component. And what I will tell you is that family-led crisis planning, about in 2015, nationally, they started having the conversation within Wraparound to use family-led crisis planning as part of that. So yes, you're going to hear this model because this is the model that Wraparound is trying to utilize more and more. And OFSN in Oregon was honored in 2015 to get to be part of that national dialogue of what does family-led crisis planning look like. And so I'm excited that you're saying this looks like Wraparound, because that means Ohio is integrating family voice like they should. It's one of the principles in that crisis planning. And so that excites me. But yes, safety planning is an element of Wraparound process.
Yes, that is true. I think they were referring to capital WARP, which is Wellness Recovery
Yes.
Action Plan, which is just slightly different. Sheamekah, did you want to speak to that? It sounded like you might have some insight.
No, I think that there are quite a few plans out there that have a similar focus. Just like you just mentioned, the Wellness Recovery Action Plan, there's a family care plan. So there are other plans out there, and I noticed that you listed a couple of them in the link. And so I think any of those plans can be adapted to meet the needs of the families in your state, community, or service area. But I really want to applaud Melissa because Melinda, I'm sorry, I want to applaud Melinda because Melinda said something that I think is really unique. We have a responsibility as family organizations to prepare families ahead of what they would consider a crisis. Whether we're talking about preparing families for, again, what a behavioral health crisis look like, or whether we're talking about preparing family for a unique crisis such as a loss of a job, what did that look like? And so I think that if family orgs abroad would have real conversations with families, helping them to understand the importance of looking ahead, kind of those preparedness, just in case something happens, what options do you have? And how do you incorporate natural supports within those options to help you be accountable through that process? So I love what Melinda said around really taking a step back to prepare families for what could potentially be ahead.
Yeah. And I'm sorry, I'm so used to people abbreviating Wraparound that my brain went right there. Yes. And so the biggest thing though that I just the WRAP program is geared towards adults. That's the really big thing. So WRAP is for adults over the age of 22 in most states. And it's a wellness and recovery action plan. And then Wraparound is a process for youth and children in and working with their families. And so, but a lot of the same principles. That's one thing I love about everything we're talking about, whether it's system of care or now looking at the mobile response teams and 988, it really is this shift in mindset of looking at how do we think about the whole individual? How do we think about the whole family? How do we be holistic around it versus just being systematic with it?
Yeah, and I think what you were talking about, Melinda, was the difference between a plan and a family-led plan, and you laid that out very, very well.
Right.
And one more question from Belinda. Who does the training for this family-led crisis planning?
So in Oregon, it's OFSN and myself. And this training is virtual. And so we offer it to anybody around. I mean, anybody can come to it. We just had one earlier this month, and we had people from Guam. We had people from we had all over. And so But I would say that family-led planning or person-centered planning is a concept that's been out there for a long time, and there's lots of organizations that do this type of planning. And like I said, if you want more information about the way that OFSN does it or the way Oregon does, feel free to reach out to me, and I can show you that. But there's a lot of organizations that do this type of training.
Yes, and I popped a link in earlier to the National Federation of Families affiliates. Melinda works for our Oregon affiliate. There are affiliates all over the US who have family peers who do this work. They work directly with families to develop family-led crisis plans. And to educate them about the turning points that Susan spoke about, that are the signs and symptoms, to educate them about 988 and how to connect with them and other community organizations like Sheamekah talked about. Unfortunately, we are right at the end. If I could just get each one of our presenters to give me a 1-minute answer, what is the most important thing families can know about crisis planning? We'll start with you, Susan.
The most important thing I feel like families can know is the resources that is available in their community. And by that, I mean, go out, set up in your community. If there's events, if there's things going on, go to the schools, go to different things that is going on. Become your community's pack. When I say become your community's pack, become a part of them. When you say, well, I don't want to go over there, you go over there. Go over there because they need us too. And sit down and get to know them. And once they get to know you and they realize, oh, there's Miss Susan, she's just coming over to bring the kids popsicles, or she's just coming over to do this with us today, or go volunteer at your food bank, go volunteer here, do different things in your community and branch out different things and start there. And then you get to know your families. And then you get to know, hey, this is Miss Susan. She does this. She does that. And the families start talking to you then. Then you can bring in the plans like they talked about, Melinda talked about, to where you can say, hey, this is available to you. Always talk about 988. I have a granddaughter, just left 3rd grade. She knows from kindergarten what 988 is.
Great.
I mean, teach your kids.
Thank you, Susan. Resources, get involved in the community. Thank you. Sheamekah, what's the most important thing about family-led crisis that we can teach families?
Well, I think that I'm going to put on my Oprah hat today, and I'm not going to say you get a car and you get a car and you get a car. I'm going to say you matter, you matter, you matter. I think the one thing that is that we all can say that we're all of us, all 166 people on this Zoom today, we're all family members in the context of families, and our families do matter, and families do matter. Shout out to SAMHSA for the 988 implementation to let us know that we really matter, and mental health parity was extremely important. But again, I'm still going to walk back to Melinda's presentation because I think the highlight of this today is the fact that our families matter. And if we want to really begin to track back, we must put opportunities, trainings in front of family members. We must help them to prepare for their next crisis. And so, irregardless of what type of format that you utilize, you can always go on Google and Google family plans, family care plans, wellness plans. However, those can be implemented. It doesn't take a degree to implement those. Those can be implemented in your community, with your church. Those can be implemented with your civic groups across the state, because all families matter. And at some point in time, we will all face a crisis. Okay. Yeah. So families do matter.
Thank you, Sheamekah. And Melinda, really quick.
I was going to say really quick. I would say every human being is going to experience this crisis all the time. So normalize it, normalize it, normalize it. A crisis does not mean you're broken. It does not mean that your family is broken, nor does it mean that you did anything wrong as a family. And so I would say crisis happens, and it's okay. It's okay that it happens. It's okay that it happens to me. It's okay that it happens to you. And lastly, that you have strengths. You absolutely, in the midst of the crisis, have strengths and have qualities that you can use to strategize.
Absolutely. Thank you all very, very much. We have a wealth of resources that were shared in the chat, and Nashville has been so kind to say they will send those out with the slides and a recording of today's event. The very last slide that you're going to get has a couple of links to our past events in this series about family-driven support for people with serious mental illness and serious emotional disturbance. So make sure to watch the recording about collective impact and how organizations can collaborate to have a stronger impact on crisis care for people with SMI and SED. Our last week presentation was about emotional CPR, which is a really great tool for family members of those with SMI and SED. The recording for today's session will be sent out to you, and then make sure to join us on August 6th for our very last event in this series. It's about crisis intervention teams and how they can partner with families of loved ones with SMI and SED. The link to that is in the chat, so you can go ahead and register now. Please, please, please take our feedback survey when you exit the event. It should pop right up on your screen. It really helps us understand what kind of topics you enjoy hearing about, and it also shows SAMHSA the importance of having events about family-driven supports and systems. So we thank you very much for being here. Melinda, Susan, and Sheamekah, thank you so much for sharing your wealth of knowledge with us. And we look forward to seeing you all at our next event. Bye.
Thank you all so much for attending today. We are incredibly thankful to all of our presenters, SAMHSA, and the National Federation of Families for hosting this informative session. Please take a moment to complete the survey. As Dana mentioned, it will open as we close the session. This concludes today's event, and you may now disconnect.